Okay. Thank you so much for your time this evening. So for those who don't know much about IPQ Academy, I'd like to give a small introduction about IPQ Academy. So IPQ Academy is a dynamic scientific academy and study group. This is led by Tabrika Mohammed. This academy is dedicated to educating and training infection preventionists with a strong focus on promoting CIC certifications. This helps our infection preventionists to build successful IPC program and design trainings to meet specific requirements. At IPQ Academy, we believe in collaboration. We have collaboration with a lot of organizations like Saudi Society for Infection Prevention, MENA FHSS, and Beyond Experts. And by collaborating with these organizations, we also promote CAC certifications and other educational activities. And our members in IPQ Academy are experts with varied medical and education backgrounds, and they teach our students with the latest research and evidence-based practices and help in succeeding in this critical field. Whether you're just starting out in infection control or looking to enhance your skills with us or to keep in touch with the experts in the field, IPQ Academy is definitely a perfect partner for your professional development, and learning is definitely enjoyable with us with our weekly quizzes, mock exams, daily discussions, free webinars, and many more activities. So for today, we have our special speaker, Aulin Vitus. She's an expert in the expert healthcare professional with a wealth of knowledge, coming from a nursing background with 5 years of critical care experience and 6 years in the field of infection prevention. She earned her CIC certification in March 2021, which definitely shows her commitment to the field and professional development. She didn't stop there. She also obtained a diploma in infection prevention and control. And intrigued into the field of research, she earned her certificate in clinical research recently in October 2022. This definitely shows her dedication and passion to continuous learning and excelling in this field of challenges and critical things. We are extremely happy and are waiting to gain more knowledge from you, Aulin. Over to you.
Thank you so much, Lakshmi, for this wonderful introduction. Let me share my screen. Good evening, all. Thank you so much for joining with us today. Myself, Aulin Vitus. So we will be discussing about the healthcare-associated infection surveillance, and during the discussion, we will go through in detail about the various aspects of the HAI surveillance and in detail how you can plan the surveillance in your healthcare facility. So shall we start now?
Yes, we can.
Okay. So during our discussion, our learning objectives are, by the end of this lecture, you will be able to explain the basic concepts of epidemiology and their application to the high surveillance and the aims of healthcare-associated infection surveillance and how you can establish a framework of surveillance in your healthcare facility and how to plan the initial steps of high surveillance and how to assess the surveillance of the target population and how you can select the surveillance outcomes and how to use the standardized high case definitions and how to prepare the report out of the surveillance and how you can communicate this report with your management or to the administration level and describe the objectives and elements of herd surveillance and describe the need for continuous improvement of surveillance system after the evaluation. So these are the learning objectives. By the end of this lecture, I hope you will understand all these elements of our discussion. Let's go to the what is mean by surveillance. Actually, surveillance is derived from a French word. Serve means over and veilleur means watch. That means watch over. It is the close and continuous observation of one or more persons for the purpose of direction, supervision, and control. And it is the systematic observation of the occurrence and distribution of the disease and their risk factors within a population during a defined time period. And infection control surveillance is not about assigning a blame and not about fairness, but it is about evaluating a system. And after evaluating the system, we can identify the preventive measures, how we can implement our infection control prevention system according to the surveillance. So this is the main aim of the infection control surveillance. We will go into some definitions afterwards. We will go in detail about the surveillance aims part. Okay. So definition, when it comes to the definition, what is meant by healthcare associated infection? These are the infections which is the people are getting during the process of receiving care in a hospital or a healthcare facility, and which is not present or incubating at the time of patient's admission to a healthcare facility. And what is meant by surveillance? It is an ongoing, systematic collection, analysis, and interpretation of the evaluation of data and closely integrated with the timely dissemination of this data to those who need it. So this is not about just ongoing collection or analysis or interpretation or evaluation, but it is about we need to communicate and timely we have to disseminate this data with the administration level so that they can take appropriate action. And what is meant by hospital surveillance? It is an ongoing systematic collection, analysis, interpretation, and dissemination of the health data to help guide clinical and public health decision making and action. And what is meant by case definition? It is a set of uniformly applied criteria for determining whether a person should be identified as having a particular disease or injury or any other health condition, and which usually includes the clinical data, laboratory data, and other diagnostic criteria of the patient. And what is meant by cluster? Group of cases that occurs closely related to a time or and in a place without regard to whether the number of cases is more than expected or not. Often the number expected number is not known because we don't know what is the expected number of the infections within a hospital. So by during the surveillance, we will come to know that. And what is mean by epidemiology? Epidemiology is the study of the distribution and determinants of health-related states and events in a specified population and the application of this study to the control of health problems. In this, I just explained what is meant by study. Study can be scientific, systematic, data driven, and what is meant by distribution. This can be a frequency or a pattern, and what is determinant. This can be the causes or risk factors of this infection. And events are not just diseases, which is more than that. And in specified population means the patients in a community, we can do the surveillance in a community, and also we can do surveillance within a hospital setting, and within the hospital setting itself department ways we can divide the surveillance. We will go in detail in the next slide, like in the target population, what is the target population in our surveillance. So in that session we will discuss about this in detail. And the application, what is the application, which is can be we can apply this application of epidemiology in the public health. Then why we need surveillance in the healthcare settings? Nowadays, you know that the MDR, the multi-drug resistant organisms are getting high in number, and also the vulnerable population and immunocompromised populations are increasing. So we need surveillance to determine the status of the current healthcare system, and also to this surveillance will also the healthcare associated infection, which is causing an imbalance between the resource allocation and also the preventable conditions. So because we have the resources in our healthcare setting to give care for the patients. If you are not managing the patients and the patients are developing infection, in that case, the resources we will be using for the treating the patients with the infection, which we can use for other purposes to improve the patient safety. And evidences shows that when we are implementing the appropriate surveillance system within a hospital, this itself will alert the healthcare professionals, and also which will improve the healthcare infection prevention control system within a hospital, and will by instance which will reduce the incidence of healthcare associated infection in a hospital. And also this will help to monitor the effectiveness of the prevention control programs which we are implementing within the hospital settings. So which we can identify whether it is effective or we need to modify our practices or not. Also, which will help us to identify the outbreaks and in a at early as possible. And what are the aims of healthcare associated infection surveillance? which will determine the baseline and endemic rates of occurrence of a disease or event. And also, this will detect and investigate the clusters or outbreaks, and this will assess the effectiveness of our, as I mentioned earlier, this will give us an effect, this will help us to assess the prevention and control of activities, whether it is effective or not. And also, this will help us to identify the potential risk factors of this infection. And also, we can implement this into the performance improvement activities within our organization. Also, we can implement in our quality improvement project, we can improve. And also, we can observe the practices, whether the infection control practices, what we are following in our hospital, whether it is enough to control the prevent of infection or not. Also, to detect and report the notifiable diseases to our healthcare authorities. And then we can also identify the multi-drug resistant organisms, any other communicable diseases, and also we can measure whether it is the compliance with the state and federal regulations or not. And this is one of the mandatory requirements of the Joint Commission International Accreditation Agency. And also, according to the surveillance we make, we can provide education to the healthcare providers and monitor the injuries and identify risk factors for the injuries of the personnel. And also we can detect if there is any bioterrorism attack or any emerging disease within our healthcare facility. And we can early respond to the infectious diseases during an emergency or during a pandemic. And we can provide data to conduct the facility risk assessment. So these are the aims of why we are doing the healthcare associated infection surveillance within our settings. Then coming to the question for you all. So yeah, I'll just read the question for you, then you can select the appropriate answer. Which of the following are the reasons to conduct healthcare associated infection surveillance? 1. Provide baseline endemic infection rates. B. Identify increases in the infection rates like clusters and outbreaks. And C. Measure the impact of implementing IPC interventions. And D. Provide data for internal benchmarking only. So what do you think? Why we need to do the healthcare associated infection? Which are the following reasons? You can comment your answers in the chat box. You can just give 1 minute for you to think and answer.
Please use the chat box to write your answers. So the answer is A. Other participants, please use your chat box to answer. There is another answer, C.
The question is select all that apply. So that means you can select multiple answers, not just one.
There is an answer A, B, C.
Okay. Okay, we will move forward. So the answer is select A, B, and C. And why not D? Because the answer D is provide data for internal benchmarking only, which is not correct because we are using the data for external benchmarking as well. So the answers are providing baseline endemic infection rates and to identify increase in the infection rates within the facility and measure the impact of our infection prevention and control interventions. And what are the basic principles of HIS surveillance? It should be based on the sound epidemiological and statistical principles, and they can provide information to improve our quality outcomes and to improve the outcome of the healthcare care which we are providing, and also to promote the public health. And those who are responsible for implementing the healthcare associated surveillance, we should be familiar with the basic principles of epidemiology, and we should familiar with the basic principles of statistics, how we can apply the statistics to identify the healthcare associated infection rates within our facility. So these are the basic principles of high surveillance. Then coming to the how we can establish a framework of healthcare associated infection surveillance within your healthcare facility. So what are the steps? One is to select surveillance methodology. After selecting surveillance methodology, we have to define the population whom you are going to study. We will go in detail about each points in the next slide. Then we will choose the events to monitor and selecting the outcome or process for the surveillance and determine the time period for observation and identify the surveillance criteria means the case definition and using the surveillance definition and identify data elements to be collected and determine the method of data analysis, and after determining the method of data analysis we will determine what data to be collected and how we can manage the data, and at last we will be preparing a surveillance report and we will be distributing and communicating this surveillance report with the concerned persons, and we will be evaluating our surveillance report. So these are the steps in establishing a framework of healthcare associated infection surveillance. Now let's go in detail about each step. So step one is assess the population to be surveyed. In that we will be assessing evaluating the whether in our within our healthcare facility what are the populations what we are caring, in that what are the high risk population, what are the high risk procedures, and what are the high impact of infection within our facility, what are the high cost infection. So identifying all these things you can go through some questions. When you put these questions within your healthcare facility you will come to know what type of surveillance program you can design within your healthcare facility. What are those questions? What type of infections? What are the patients receiving care, like pediatric, whether geriatric patients or only critical care patients? This you can identify first. Then type of care you are providing, whether it is intensive care, surgery, chronic diseases, and what are the common diagnoses that you have in your hospital, maybe the cardiac cases, burns cases, and what are the invasive procedures that you are most frequently performed, like central line insertion and whether the patient is on ventilator or not, the number of peripheral lines, central lines, and surveillance outcome to be targeted, what you have to target for the outcome. So when you are questioning these questions within your healthcare facility, you will be having an idea how we can plan the next steps in your healthcare associated infection surveillance system. Then coming to the selecting the outcome. So what is the outcome? What do you gonna select as an outcome of your surveillance? This can be process indicator or the outcome indicator. So what is mean by process indicator? This structure and process indicator which will help whatever changes we are making in our structure and process indicator, ultimately our outcome indicator also will be changing. So in the structure indicator, what means? That means how many hand washing stations you have, whether you have enough isolation rooms in your healthcare facility or not. So these are the examples of the structure indicator. What are the examples of process indicator? In during the process indicator, you will go into the actions of the healthcare workers, whether they are performing the procedures in a correct way, like for the COTI, whether they are COTI insertion using all the proper precaution or not during the CLAPSI, for the central line insertion, are they following all the sterile techniques? Are they using all the sterile their criteria for using the central line insertion? So all this when you look into the process, whether they are following the correct steps of hand hygiene. So these are the examples of process indicators. And then what is meant by outcome indicator? This is the endpoint or result of the performance. Examples include the number of CLAPSI, number of COTI patients, number of VAE patients within your healthcare facility. So these are the examples of the outcome indicators. Outcome is number of the infections or number of the output, but whatever process or structure indicators that you are providing, this is the output measure that you are measuring. This is the outcome indicators. I hope you understand what is mean by structure indicator, process indicator, and outcome indicators. Next, coming to the question for you, tracking whether the healthcare workers are properly disposed of sharp waste is an example of which kind of indicator? Process, structural, or outcome? You can comment your answers in the chat box. Tracking whether the healthcare workers properly dispose of the sharp waste is an example of which kind of an indicator?
There is an answer. Answer is one answered A, one answered C. The other one is A. So most of them go with the option A. A, E, yes.
So what we are doing it here? Here we are checking whether the healthcare workers are performing in a correct way or not, correctly disposing the sharps in the sharp bin or not. So this is a process indicator because we are checking the process or the actions which are taken by the healthcare professionals. So what a process indicators are tracking or enables the key steps that results in the changes in the outcome such as tracking the healthcare workers' behavior. So this answer is process indicator. I'll give you one more question. So just read the question, then answer it in the chat box. Tracking whether there are enough alcohol-based hand rub dispensers within easy reach of whether healthcare workers are performing bedside care is an example of which type of indicator? Process indicator, outcome indicator, or structural indicator?
So they are answering C. Most answers are C. Most
Great.
all.
So here we are checking the structural outcome because whether there is enough alcohol-based hand rub within reach of healthcare workers, this is a structural indicator because um, we are checking whether it is easy within easy reach of the healthcare workers because this is a part of structural outcome. Then coming to the next step, that is use established case definition. So what is meant by case definition? A surveillance case definition is a set of uniform criteria used to define a disease that enables the healthcare workers to classify and count cases consistently for the surveillance purpose. Always we have to use the standardized case definition. Why? Because by using the standardized case definition, we can compare our data with the external factors like benchmarking we can do as long as we are using a standardized case definition. I will just give two examples of the standardized case definitions which we are using from the NHSN and CDC. One is the whole hospital acute infection HA. A case definition of HA is that date of infection or event occurs on or after the third calendar day of admission to an inpatient location where day of the admission is the calendar day 1. And what is meant by present of admission? Date of event or site-specific infection criterion occurs on the day of admission to an inpatient location, that is calendar day 1, the 2 days before the admission and the calendar day after the admission, that is present on admission time period. So these are two examples of the case definition which we are adopting from the NHS and CDC criteria. This is just an example. There are many examples of case definitions which are standardized, which we can adopt from the NHSN or from the CDC. I'll just give one more example of VAE criteria which we are using from the NHSN. I'm not going in detail about this chart because as you already aware about how we can maintain the VAE surveillance algorithm, this is one of the part of the standardized case definition. Then coming to the data collection, how we can collect the data and what are the things to be, we have to keep it in mind when we are doing data collection. First, we have to develop a surveillance protocol. Then there must be a practical data collection form which can be used by even with your link nurses, they must use the data collection form. This will be easy for them to use for the data collection for the healthcare associated surveillance purpose, and also identifying the data collection system. And you have to training the surveyors, they must be trained enough to collect the surveillance data and establishing the data quality. Make sure that you are not missing any cases. You are collecting the validity of the data. It depends upon the quality of the data. Then coming to the what are the data you are collecting, you will be collecting the numerator and denominator data according to the calculations or the rate that you are going the data, how you're gonna manage in the further steps. So once you identify that, you will be collecting the numerator and denominator data accordingly. And what all things you will collect in the numerator data? You can take it from the laboratory report, you can collect it from the nurse's note, and when you go for the ward rounds, you'll be collecting the data also for the hand hygiene and all, and also the admission and discharge criteria. So accordingly, then you will list down the patients, those who need further investigations, and from that, what you will do, the patients, those who need further investigation, you will follow the chart review, and you will also will follow up the WhatsApp, and also the unit managers you will follow, and accordingly you will check whether this patient meeting the case definition or not. If the patient meet all the case definition, the standardized case definition, then we will report this as this patient developed a healthcare associated infection, maybe CORT, CLABSI, or SSI, VAE. So according to the case definition, whatever the case definition what we mentioned earlier, whether this particular patient meeting all this criteria, then we will report this patient as healthcare associated infection. So these are the data we are collecting in the numerator data. Then what all things we will be connecting in the denominator data? Denominator data will be the count of the procedure. For example, for the exercise, if you want to collect data for the SSI, you will look into the surgical procedures, the total number of surgical patients underwent surgery and during that surveillance period. It is very important to make sure that the surveillance period, these patients in the numerator data and also in the denominator data must be present at the same surveillance period. And for healthcare associated infections, specific devices like indwelling urinary catheter, central venous catheters, and daily collect the total number of patients admitted and the total number of device days. And these are the data you will be collecting for as a part of the denominator data. So we are collecting the numerator data and also denominator data during the data collections process. And here comes one question. To calculate the catheter-associated urinary tract infection rate for unit for particular month, the denominator data should be dash. The number of patient days for the unit of the month, the number of admission for the unit for the month, the number of patients with urinary catheters for the month, the number of urinary catheter insertions for the month. So what you will be collecting as the denominator data when you will look into the COTI rate. You want to calculate the COTI rate in your facility. So what is the denominator data that you're going to collect? You can comment your answers in the chat box.
Answers goes with option C, and there is one option B. Yeah, everyone goes with option C. Number of patients with urinary catheters for the month.
Good. So for this, the answer is C, the number of patients with the urinary catheters for the month. So in this, what are the important? We will go into this formula in the later section. So the rationale is there are three important aspects of the formula while determining the COTI rate. One is the persons in the denominator must reflect the population from which the numerator was taken. For example, in the month of May, you are taking the patients, you want to calculate the number of 40 infections, you will check the patients with the infection divided by the patients with the catheter during that calendar month, like in the month of May. And counts in the numerator and denominator should cover the same time period. And the persons in the denominator should have been at the risk or event of occurrence, that is, the number of patients with the urinary catheter. I hope you understood this question. We'll move forward. Another question, you are reviewing a medical record of pediatric patients. The record of Anchandro, a 4-year-old boy, is incomplete. So you're not sure whether this patient has BSI or not. How you are going to do? Are you going to count this one into the denominator or no? You can comment your answers in the chat box.
Answers in the chat box. Answers coming through. They're supporting no. They say no.
Good. So the answer is no. Because as long as we don't know the status of the patient and when the record is incomplete, we cannot calculate this patient into the denominator data. Then we have to be forced to exclude this pediatric patient from both from the numerator and denominator data because we don't know the actual status of the patient because the record is incomplete. So whenever you have a doubt about the patient data, patient record, whether you are thinking that the data is not enough to conclude whether the patient has infection or not, you have to minus or exclude this patient both from the numerator data and also from the denominator data. Then coming to the methodology of data collection, we will be looking into the incidence and prevalence data mainly. What is mean by incidence and what is mean by prevalence? This is a common topic and also this is a very common question in our CIC examination. So incidence are number of persons in a population who develop a disease within the specified time period, and these are the new infections, new cases in a specified time period. And what is mean by prevalence? These are not only the new, also the existing cases within a point of time or a period of time. This is called prevalence. So this is the difference between incidence and prevalence. Incidence means only the new cases during a specified time period, but prevalence means existing and also the new cases during the particular time period. Then the another methodology is the passive and active surveillance. What is mean by passive surveillance and what is mean by active surveillance? In the passive surveillance, mainly we'll be looking into the patient records and also the reports from the laboratory and also from the healthcare providers, whatever the information we are getting from them, we are including into the surveillance. So this is the method of passive surveillance. And we are usually not doing passive surveillance, we will be doing the active surveillance. So what is mean by active surveillance? We are actively searching for the new infection or actively searching for the risk factors. And how we are doing by the generating by the period of time. Mostly active surveillance will be prospective, not the retrospective. In the passive surveillance, we will be looking into the retrospective data, looking into the backward and all. But in the active surveillance, always you will be looking forward. We are looking prospectively for the occurrence of the infections. And we will be checking whether the patient meeting all the standardized case definition criteria or diagnostic criteria of developing healthcare associated infection or not. So this is the difference between active and passive surveillance. Then let's discuss the advantages and disadvantages of passive and active surveillance. In the active surveillance, it is more complete reporting than the passive surveillance and more timely and accurate information, more representative data and more data quality. And when it comes to the passive surveillance, it is less resource intensive and also underreporting is more common and simpler and less work with the passive surveillance, inexpensive and less time consuming. Because in the passive surveillance, we will be going into the retrospective way. Then coming to the prospective and retrospective surveillance, but as I mentioned earlier already, prospective surveillance means we will be looking forward by the doing what is going to what will be happening next, like during interview with the clinicians, monitoring the current patient records and data collections. So during the prospective way, in a retrospective means we are checking into the medical records or post after the discharge of the patients, we will be reviewing the data and all. This is coming into the retrospective data collection. These are some advantages and disadvantages of retrospective and prospective surveillance. For prospective surveillance, we can quickly detect the clusters and outbreaks and good for high risk patients. And in the retrospective, it is less time consuming, less resource intensive, and difficult to obtain the missing data. Because in the retrospective surveillance, most of the patients might have discharged already. So it is very difficult to get a missing data in that case. But in prospective surveillance, if the patient is already in the hospitals, it is very easy. We can get all the data from the patient records and also from the other resources. Then coming to the hospital-wide and target surveillance. In the hospital-wide surveillance, we'll be looking into the output as a whole hospital. and the data are collected for all the infections, irrespective of the unit, whether the patient is in which department. We are not looking, we are checking in the whole hospital data. But in coming to the targeted surveillance, we'll be looking specifically into the particular infections, for example, or else particularly for some departments like pediatric ICU or adult ICU or burn unit. So this can be a targeted surveillance. And also during the target surveillance, there is an important thing that we might miss the clusters or outbreaks in our patients. But in whole hospital-wide surveillance, we can very easily understand the outbreaks because we are checking into the whole hospital data. So the changes we can easily identify this one. As I mentioned already, the total or whole house surveillance is that the HIs are monitored in entire population of a healthcare facility. But if targeted surveillance, it is focused on particular units. And most of the times we'll be going for the combination of the surveillance strategy. In almost all the hospitals, we'll be checking both the things. We'll be checking the whole house surveillance and also the targeted surveillance. And there comes some advantages and disadvantages of hospital-wide and targeted surveillance. In the hospital-wide surveillance, it detects very easily uh, detects the clusters and outbreaks very easily, as I mentioned already. And also, this will give us a baseline rate within our hospital, but it will not help us to determine a valid denominator. And targeted surveillance, it will help to determine the valid denominator, and it is less resource extensive. And in the hospital-wide surveillance, it will give us too much of data. And in the targeted surveillance, the objectives will be well defined. Then coming to the laboratory versus patient-based surveillance. As the name itself, laboratory surveillance means the surveillance which are getting from the positive lab findings, and also the diagnostic therapeutic test. For example, for the pneumonia, we are checking the laboratory data whether there is positive culture or not, and also for the Klebsiella and all, we will check on the laboratory data. So this is the laboratory surveillance, and in the patient-based surveillance, we will be looking into the clinical data. Especially, we will check whether the patients for events and risk factors and the procedures data of the patients and practices of the healthcare professionals and the patient charts, discussions with the caregivers. These all will be coming into the patient-based surveillance. So there are two types of surveillance: laboratory-based and patient-based. And this comes the question, for which surveillance method is it more difficult to obtain the missing data? Active surveillance, retrospective surveillance, laboratory-based surveillance.
So answers goes with option B.
Good. As we already discussed earlier, in the retrospective surveillance, it is very difficult to get the data because most of the times the patients already might have discharged. So it is very difficult to get the missing data in that case. The answer is retrospective surveillance. Then coming to the data analysis. Data analysis means how you're gonna analyze the data, how you're gonna do the you will apply the statistics in the data analysis and all. So basically, what are the basic statistical measures that you're using in the surveillance? One is the measures of frequency, like examples, rates, ratios, and proportions. And the one is the measures of central tendency, as you already know, that is mean, median, mode, and measures of dispersion, example, the standard deviation, percentiles. So these are the basic statistical measures which you are using in our surveillance system. Then coming to the calculation formulas for calculating the CLABSI rate, how we are calculating? We are calculating the number of CLABSIs in a particular location divided by number of central line days in that location into 1000. 1000 is a constant. And how you're going to calculate the device utilization rate for that particular number of central line days divided by the number of patient days. When it comes to the COTI rate, it's the same number of COTIs in that particular location divided by number of catheter days in that particular location into 1000. And for the device utilization rate, number of urinary catheter days divided by the number of patient days. When it comes to the ventilator associated event rate, we are calculating for the 1000 ventilator days. That is number of patient with VAE in that particular location divided by number of ventilator days in that location into 1000. Device utilization rate, as I already mentioned, this is same number of ventilator days divided by number of patient days. And coming to the surgical site infection rate, that is number of surgical site infection in a defined group of procedures divided by the number of operations performed into 100. This will give us the rate of surgical site infection. So these are the common formulas which we are using in our healthcare facilities for calculating the rates and ratios. Then coming to the standardized infection ratio. What is meant by standardized infection ratio? We will be checking whether the observed healthcare associated ratio between the observed infection ratio and also the predicted healthcare associated infection. For example, in a hospital A, we have 4 MRSA BSI, and the national data predicts that it is 2.5 MRSA BSI. So how you will calculate the standardized infection ratio? We will calculate in our hospital rate divided by the predicted rate. So that is 1.6. So whenever the standardized infection ratio it is more than 1, that means the infection is more than what we have expected. So we have to take proper action. We need to, there is some problem with the infection control measures which are implemented in our healthcare facility. So we must be looking into more details. We must go into the root causes of the disease and all in that case. Whenever there is an SIR less than 1, that means we are expecting 2.5 infection. For example, in this case, we are expecting 2.5, but SIR less than 1. That means we are getting fewer infection than expected. That is given baseline. According to the given baseline data, we are not going high level of infection in our facility, which is expected to have this number of infection in our healthcare facility. So whenever the SIR is greater than 1, we must implement more infection control measures to prevent further occurrence of HI within our healthcare facility. Then coming to the measures of central tendency. Well, as we already know, the measures of central tendencies are mean, median, and mode. I'm not going in detail about the statistical side. We'll be going in detail about the steps of framework of surveillance method. Just in a brief, mean means the summing up of all the values in the data divided by the total number of values, and this can be affected by the outliers. Maybe some values will be high in numbers, some can be small in numbers. So these outliers can be affected this mean. And when it comes to the mode and mode, that is most common value, and median is when you are arranging the number in a specific order, in an ascending or descending order, we will check the middle number as median. And mode and median were not affected by the outliers. So here comes the question. An IP collected the following data from the ICU for the month of March. How would she calculate the COTI rate for the month of March? We have some data, 6 COTIs, 240 patient days, 180 catheter days. So which will be the correct formula in this case? You can comment your answers in the chat box.
So the answers goes with option B. 6 divided by 180 into 1000, that is 33.3 per 1000 catheter days.
Great. So here the answer is B, because will be calculating the number of COTI infection divided by number of catheter days for that particular location into 1000. As we already discussed, so the answer will be B. Then coming to the risk stratification methodology. So during the risk data analysis, we can apply the risk stratification methodology in order to identify the data. So what all can be applied in this case? For example, for CLABSI and COTI, we can put the risk stratification according to the location of the patient. And in case of SSI, what we can apply the ASS statistics. And also for CDA, C. diff infection or MDR, or what we can apply. We can account for the disease burden or the community prevalence of this disease and also the testing method, facility characteristics. So accordingly, we can apply the risk stratification for the infections and we can calculate the data. For the, I will just give an example of the SSI risk stratification. We'll be adopting the NHS and ASA criteria. In that, we'll be doing the risk stratification according to the wound class, ASA scoring, and also duration of the operation. These all things we'll be considering in when we are assessing the surgical site infection of the patient. Then coming to the interpretation, how we can interpret whatever we analyze. We did the data analysis, we did the data collection, analysis, we applied all the methodology. So next step is the how we can interpret our infection rate. So the data interpretation should aim to identify the areas where improvement is needed to lower the risk of HAI. Infection rates may vary depend in the previous data. It can vary due to various reasons. So, for example, seasonal variations such as in the cold season, there is a chance of increased number of respiratory infections, and weekly variations beginning of the week, maybe high infection rate. This can happen, and also whenever we are changing the case definition, whenever you are changing the surveillance methodology, there is a chance that the number of infection what we are going to identify will also change according to the standardized case definition, whatever the changes we are applying on that. And the random chance is that test significance. And part of interpreting entire data is being able to compare the, like for example, for during the benchmarking and all, we need to do the surveillance, HA surveillance data to interpret, we need to do the benchmarking. When we are applying the standardized case definition, this will help us to interpret our HA data. So what are the points to be keep in mind while during the benchmarking of our data? We must make our the criteria for defining a cases are standardized, or the case definitions are standardized, up-to-date criteria are used and consistently used by the benchmarking facility and also our facility. And the population and time period for the study are well defined. For example, if you are benchmarking a infection with another facility, make sure that the same time period you will be checking. And the data collection and surveillance methodology are standardized. And the rates and ratios are calculating using the same numerator criteria and also the denominator criteria. Then the facility and population being compared are similar. For example, if you are comparing the data for the pediatric population, make sure that the data that you are comparing is for the pediatric population. For example, if for the critical care units, to make sure that it is only for the critical care units you are comparing the data which you are receiving for the benchmarking. And the report analysis and interpretation of the data provided by the benchmarking system are accurate and informed that it is understandable to the users. A standardized risk management method is used by all the participants, and all data collective receive training on how to collect the data and use the standardized form. So those who are doing the surveillance, make sure that they are receiving enough training to do the surveillance in a proper way. So these are the points to be keep in mind while we are doing the benchmarking. Then coming to the important step in the surveillance, that is the communication. So when now we planned the surveillance, we did the data collection, we did data analysis, we interpret the data. So important is that we need to communicate this data to someone who can make change in the healthcare system, or who can make changes in the improvement in the patient safety, or improvement in the less improving the number of infections, like reducing the number of infections within the healthcare facility. So communication demo, it is a demonstrable power of surveillance in sharing the findings with those who need to know and who can act on the findings to improve the patient safety. So we need to plan for the distribution of the findings. We have to prepare a report, surveillance report, and make it in a manner that it will be easily understandable by the persons, those who are receiving the data. For example, you can display the data using the charts, graphs, tables in an easy way, which will easy for the persons who can understand that one. And when writing the surveillance report, what all things to be included in your surveillance report? You have to identify the author and date of the report and state the purpose why you are conducting the research surveillance. So you have to input your goal, target, and objectives, and then define the event population, settings, period, time period to be studied, and you have to mention the what is the case definition that you use for your surveillance, what are the methodology you used, and the statistical method and calculations were used, and you have to include the results. What is the results you find out after the surveillance and interpret the findings in a way, as I mentioned, you can put the graphical or the tables or charts and describe if you have taken any action to make prevention of and control of the recommendation. And make sure that your surveillance report should be user friendly and provide accurate, interpretable information that can lead to the improvement. Displaying the data visually, like example, nihilist graph charts, may help the audience to easily understand the report. So these are the things that you have to keep in mind while you are creating a surveillance report. Then coming to the evaluation. After you communicate the report with the concerned person, it is make sure that you are evaluating the current surveillance system. So what are things you will do? At least you will evaluate your surveillance system in an annual basis. And also during your IPC committee meetings, you can present your data of how it is going on, whether you are finding any gaps in your infection control practices. So anywhere you need to change the case definition also, you can make the changes according to the surveillance methodology what you adopted until this process while during the evaluation. And also they can identify the ways to improve the surveillance within your facility. So surveillance is not fixed. Surveillance framework is not fixed. Anytime you can do the modification within the surveillance system. Ultimately, your aim is to improve the improve the infection prevention and control system within your healthcare facility in order to reduce the HAs in your facility. And what are the modifications to the surveillance system that might include, that are the reassessment of the infection monitored and changes to the approach to the case finding, ways in which the information is generated, a change in the objective. So these all can be changed during your evaluation process. Next question is that an IP has completed the investigation of an increase in post SSI following ambulatory surgical procedures. He identified some corrective measures that will require monitoring. Which of the following actions will the infection prevention team will take? You can comment your answers in the chat box, go through the question in detail, look into the keywords, and answer your question.
Please share your answers in the comment box. Okay, answer go with C. Others, please give your answers in the chat box. Okay, everyone chooses C.
Okay.
Revise the
So
facility
the correct
surveillance.
answer is C. Revise the facilities surveillance plan. So why we need to revise the facilities surveillance plan? Because we identified some gap in our surveillance system. Surveillance activities should support a system that can identify the risk factors for infection and other adverse events, implement risk reduction measures, and monitor the effectiveness of our interventions. The item noted in answer A, B, and D are rarely related to the development of SSI. The facility surveillance program should be revised to reflect the current risk and risk reduction measures. So while we are doing the evaluation time, we will identify this and we can revise our surveillance plan and we can do the modification accordingly. Then what is the importance of information technology in our HIS surveillance? Because nowadays we are not going into the manual data collection. Most of the times we are depending upon the automated or electronic surveillance, because the manual data collection is time consuming. We need more resources and there is more chance of errors, and data can be collected a long time which is needed, and data management also it is very difficult with the manual. So when it comes to the IT or information technology, when we are using, it is very easy to access the data, and very easily we are getting all the information, and it will give us a systematic collection. When you're applying this one in a proper way, this will give us a systematic collection. And also we can use this electronic system into our existing manual data collection system. We can merge the manual and automated electronic surveillance. We can merge these both, and we can uh, take the concluded part of the merge result. Then automated surveillance programs that use existing electronic clinical laboratory and pharmacy and other health data can improve the sensitivity, accuracy, and objectivity of the surveillance and decrease the burden of the data collection. So these are the importance of using the information technology in our surveillance system. And as an IP, it is very important that we must know at least the basics of the in computers. Like for example, for Excel, we must know how we can use the Excel Word format in order to do the surveillance system. And these are some references which I use for the study for this presentation. So you can go through it. Hopefully, Lakshmi, she will be sharing it in our group, so you can go through in detail. So now the time for the discussion and questions. So if you have any question related to the topic, you can put unmute your mic. You can.
Thank you, Aulin. Thank you so much for your excellent webinar. Before moving on to the discussion session, I just want to highlight the point that I have shared a link in the comment box. Please give your evaluation and feedback. And please don't forget to give your evaluation, because only after you complete your evaluation, you'll be getting the certificate of attendance. Write your full name correctly as how it has to appear in the certificate. Please don't forget. Yeah, if anyone has any question, you can write it in the comment box, or you can unmute your mic and speak to Aulin. Any questions regarding surveillance? Please open your mic and ask, or just ask your questions in the comment box. Okay. I think Aulin, there is no questions, no doubts. It was very clear. Thank you so much for your time and efforts. Tabrika, do you want to share a word? Tabrika?
Hi, good evening, everyone.
Evening.
Thank you so much, Aulin, for the informative, comprehensive presentation. It was enlightening. There is nothing to say much except that thank you. It is very up-to-date information and comprehensive, and also covering most of the important elements for the CIC preparation. Thank you, Lakshmi, for the moderation and organization.
Thank you, Tabrika, and thank you, Lakshmi.
Thank you, Tabrika. Once again, please don't forget to complete your evaluation. If you need the certificate of attendance, please complete. I've shared the link in the chat box. Thank you so much, everyone, for your time and effort. Thank you so much.